Hi, my name is Stephanie Niemeyer again, and I will be giving you the lecture on short bowel syndrome as well. So again, please find my email address here on the slide should you need it. The objectives for today are to first understand the basic functions of the intestines, and this will just help you predict the outcomes of our patients that are missing those various portions of the bowel. You should be able to list the potential etiologies of short bowel syndrome in pediatric patients because most of the time this is not a condition that the patient is born with. You should be able to explain the pathophysiology of the complications of short bowel syndrome because that is what we end up managing in these patients are the various complications. So those acronyms there on the slide are parenteral nutrition associated liver disease, small intestinal bacterial overgrowth, as well as chronic diarrhea. There's more complications we'll talk about as well. You should also be able to predict what type of complications the patient will develop based on how much of their bowel has been removed, what portion of the bowels have been removed, and you should be able to tell what type of treatment the patient will receive. And then finally, you should be able to recommend treatment options for each patient based on what complication of short bowel syndrome they develop. Today we'll first talk about the anatomy and the function of the intestines. We'll go through a few definitions until we get to the etiology, so how these patients end up with short bowel syndrome. We'll talk about outcome predictors, which patients with short bowel syndrome do the best and which ones don't do so well. How many kids are affected by this disease? Is it prevalent or not? And then we will talk about the complications. And really the treatment is centered around managing these complications. So it's really important to know how we get these complications and then how we manage them. This is a good picture of just the basic anatomy of our intestinal system, our gastrointestinal system. So not pictured at the top of the slide would be the esophagus that drops down into the stomach. After the stomach, the contents will move through the pylorus and into the duodenum. After the duodenum is the first section of the small intestines, and then the middle section is the jejunum, and it winds through your abdomen a lot. After the jejunum comes the ileum, and the ileum leads into the colon through the ileocecal junction. Then we have the ascending colon, the transverse colon, the descending colon is one of the last portions. The sigmoid colon is the last portion of the colon until it goes into the rectum until the contents are expelled through the anal canal. So not only is it important to know where each portion of the intestine is, but what is the function of each intestine. The duodenum is where things kind of mix together to start the absorption process. We get our pancreatic enzymes to further digest the contents. We get bile from the gallbladder, and we also obviously have the food that's fresh from the stomach. And digestion is definitely occurring in the duodenum. The jejunum is more notorious for its absorption, so it does a majority of nutrient absorption, including proteins and carbohydrates. The last portion of the small intestine absorbs the bile acids to be returned to the liver, so it also absorbs fats and fat-soluble vitamins, as well as vitamin B12. The first portion of the large intestine, which is the ascending colon, is where the intestinal contents are mixed with bacteria, and this is at which point we can begin to call the contents feces. Our whole intestinal system has bacteria in it, but it's definitely most concentrated in the colon. We want the small intestines to do the most of the absorption and digestion so that our body can have the nutrients we need first, and then the colon has bacteria that can then further digest things we can't and take whatever nutrients it needs to survive. So the transverse colon is where the bacteria digest the nutrients that we can't, and then the sigmoid and descending colon are the main regulators of water and electrolytes. This is more of just a detailed picture of exact locations where certain functions occur. So this is a really good study guide. It's a good visual for all the visual learners about you should know things like where are the fats absorbed, where is the calcium absorbed, where's the water regulated. Those are all really important to know because for patients that are missing that portion of the bowel, you need to know what functions they're missing out on. Moving on to the definitions for this lecture, the first one is short bowel syndrome. So what exactly defines the disease short bowel syndrome. Obviously, their bowels are short, and in pediatric patients, it means that they've lost at least 2/3 of their small intestines. For adult-sized patients, they have about 20 feet of small intestines. So, in an adult patient, short bowel syndrome is when they have 6 feet or less. Nobody really knows exactly how long a 2-year-old's small intestines are or a 14-year-old, so we diagnose it based on percentages of remaining bowel in pediatrics. Intestinal failure is when the patient is no longer able to use their intestine to meet all of their nutrition and energy requirements to maintain life, basically. So we have to give them parenteral nutrition in order to help the child grow. Successful adaptation is when the intestines are able to change and able to compensate for their loss. We see things like increase in length in the intestines after surgery, increased thickness and circumference of the bowel. We see more villi. The rate of absorption per centimeter can increase. So this is just a natural process that occurs in our bowels where they're trying to make up for what has been lost. And our younger patients are more likely to develop a successful adaptation versus our older patients, such as adults. As I said earlier, patients are not generally born with small bowels or short bowel syndrome. It is a post-surgical diagnosis. So these patients all have portions of their bowel cut out for different reasons. And one of the most common reasons is necrotizing enterocolitis, which is an infection that neonates get. We're not exactly sure what causes necrotizing enterocolitis. We've identified various risk factors, and we're always thinking about it for our patients that are in our neonatal ICU. But it's basically the bowel becomes necrotic. You see lots of free air trapped within the intestinal walls, and most of the time the patient has to go to surgery to get the the necrotic tissue out before it spreads. Another one that we see commonly in our neonates is meconium ileus, and meconium is the first stool of the patient's life, and ileus is like a plug, so you might also see the term meconium plug, and that's just when the first stool just gets stuck in the intestines, and then part of that portion of the bowel becomes necrotic and has to be removed. Hirschsprung disease is actually a disease of the nerves. It is when various nerves that innervate the peristalsis of the intestines just don't develop. So the patient will basically have a paralyzed gut in one region, and it's very likely that that portion becomes necrotic and has to be removed. The mesenteric artery is the main blood supply for most of our intestines, so if we have any type of abnormalities that deprives the intestines of blood supply, then clearly they will die, so this can be a common reason for having a portion of the bowel removed. Gastroschisis and omphalocele are congenital disorders, and they're similar in the fact that the intestines are grown outside of the body, so we can detect it prenatally. However, they're different because gastroschisis, there's nothing around the intestines. They're outside your body. It almost kind of looks like spaghetti noodles outside of the body, whereas omphalocele, they are inside of a sac. So it's more like a bubble outside of the body that has the intestines in it. And the way that this turns into short bowel syndrome is because throughout the process of trying to get the intestines back inside the body, it's very hard to keep the intestines moist enough. If the surgery takes multiple days, there's lots of insensible losses through the intestines. It's also hard to keep them getting enough blood supply while they're outside of the body. So also there can be some unpredicted twisting and malrotations of the gut throughout this procedure. So very often these two disease states lead to short bowel syndrome. And then a reason for some of our older patients, such as our teenagers, to get short bowel syndrome is from inflammatory bowel disease, like Crohn's disease and ulcerative colitis. We can predict how well a patient's intestines will adapt and how well they will be able to survive without various portions of their bowel. So the younger the patient, the more likely they are to adapt. Whether they had an underlying diagnosis that was just a single occurrence, such as like the meconium ileus, if that was a really small portion and we remove that portion, but the rest of the gut is healthy, then the patient might be able to adapt very well post-surgically. However, for patients that have Crohn's disease, where potentially their entire bowels could be affected by the inflammation, then even after surgical resection, they might not have much, the gut that's remaining might not be very functioning. Obviously, the length and whatever portion of the bowel is left or what is resected has an effect on the patient. Whether they have the ileocecal valve and or colon is a big deal because that's where all of our water regulation occurs. So if the patient can't maintain hydration or electrolytes, that's a big concern, not only on survival but on quality of life. The intrinsic adaptive potential of the remaining bowel kind of puts the first two bullets together. So how well are the intestines able to make up for the portion of the bowel that's lost? It's also really important to consider how healthy the other organs are that assist with digestion and absorption. Losing portions of the bowel puts a lot more stress on these other organs, and are they able to handle that stress can determine how well a patient will do. And we'll also talk about bacterial overgrowth a little bit later, but if we have colonic bacteria that moves up to the small intestines, this can lead to scarring, decreased nutrient absorption, and also cause a lot of hospital administrations, office visits, and have a big effect on quality of life. So how many patients are actually affected by short bowel syndrome? And it's actually fairly common, especially if any of you go on to work in a hospital. You will definitely know who your patients are with short bowel syndrome because you'll be managing their TPN. They'll come in sometimes a couple times a year for various complications of the syndrome. We see it about 1,200 births per 100,000 live births. Although we are able to have these patients survive, especially immediate postoperatively and throughout their childhood, only less than a third of them, closer to a quarter of them, will survive into adulthood. So it is considered one of the most lethal conditions in infancy and childhood. And unfortunately, since we are able to keep these patients alive longer, it's actually the methods in which we are keeping them alive that's also causing their death, if that makes any sense. So parenteral nutrition is the cause of hepatic failure in these patients. It causes for 60% of deaths in our pediatric patients with short bowel syndrome, and the other 10 to 20% of deaths are caused by sepsis. And most of the ways that the patients get sepsis is through their central line catheter. The rest of the lecture will pretty much focus on our complications. We have immediate postoperative complications and we have chronic complications of these patients. Obviously, malnutrition is a chronic complication. We've lost a lot of absorptive surface area for the patient to be able to absorb nutrients. So most of the time, they're a little bit smaller than their peers. They're on the lower end of the growth chart. And in infancy, they can even be diagnosed with failure to thrive. Parenteral nutrition, while it has saved a lot of life, it can also lead to liver disease, which can unfortunately end a patient's life. Central venous catheter complications are also very common in these patients. Malabsorptive diarrhea and fluid and electrolyte imbalances, micronutrient deficiencies, gastric acid hypersecretion, anastomotic ulcers, as well as bacterial overgrowth. So treatment, we have the immediate postoperative management for these patients. It's really just getting them out of the hospital and home is what we're worried about in this stage. We'll immediately worry about hydration and electrolyte balance, trying to manage the diarrhea because it will be most severe and postoperatively. They will have gastric acid hypersecretion, so we'll definitely put them on some type of acid suppression therapy. And we will put them immediately on parenteral nutrition, but our goal will be to get them onto enteral feeds as soon as possible. We always implement the trophic feeds postoperatively, and this is just to remind the gut that we do plan on using it. It helps stimulate the intestines, helps keep them alive, and we will advance the enteral feeds as much as we can, as fast as we can. We really don't want to keep the patients on parenteral nutrition. And then obviously postoperatively we will have wound care, which we won't discuss in this lecture, but It is important to consider because the abdomen is one of the slowest places to heal just because it is so soft and flexible. Our lecture will really focus on the chronic management of the complications that develop with short bowel syndrome. Our number one focus is always adequate nutrition. This is where the patients are lacking the most. We just need to get them their basic energy needs. We need to give them enough so that they can continue to grow and develop like a normal child. However, we always want to do this enterally. If we don't use the gut, we're going to lose the gut. And bowel adaptation can continue to improve for up to 2 years post-operation. So if the patient's still on parenteral nutrition, even a couple months out of surgery, there's still a chance that we can maybe get them off parenteral nutrition. But we want to always maximize our enteral feeds. The patient will develop liver disease if they are dependent on TPN for their nutritional needs. So we want to do everything we can to slow this progression or to even prevent the liver disease for as long as we can. They most likely will have chronic diarrhea, especially if resection of the colon is involved. So we'll want to do everything we can to suppress that. Obviously, we will always be worried about their fluid and electrolyte balance and making sure that that doesn't go untreated or unaddressed. They're also at risk for micronutrient deficiencies, so we'll want to make supplements whenever we can. We'll have them on acid suppression for gastric acid hypersecretion, as this can become a chronic issue as well. We'll manage their bacterial overgrowth, which we'll go on more in depth in later in this discussion. We'll talk about various surgical procedures that we can recommend for these patients, and then we'll finish up with investigational therapies. So where is the treatment of short bowel syndrome headed in the future? The first complication that we'll talk about is parenteral nutrition associated liver disease. So if we are unable to get the patient off of parenteral nutrition because they've just lost too much of their bowels, or the bowels are unable to adapt and unable to absorb enough nutrients to keep them alive, we will have to keep them on parenteral nutrition. Parenteral nutrition has eliminated the mortality of short bowel syndrome due to dehydration and malnutrition. However, it still accounts for some of the morbidity because of the fact that it's administered parenterally through a line, and because it does lead to liver disease. So we do see a lot of our complications from short bowel syndrome arise from the parenteral nutrition, but these patients are also dependent on the nutrition in order to stay alive and meet their nutrient goals. Parenteral nutrition-associated liver disease occurs in about 40 to 60% of infants on prolonged TPN, and in these studies, prolonged TPN was 30 days. So patients that are on parenteral nutrition for life, it's not a matter of if they will develop liver disease, it's just a matter of when. It does cause chronic, progressive, permanent changes in liver histology. Risk factors are premature birth, just because their liver is very underdeveloped already at birth, and then premature it's even more underdeveloped. Any patient that has any type of disruption of the enterohepatic circulation of bile acids, because they can get caught up in the liver and cause a lot of biliary sludge that leads to more histocyte damage. Bacterial overgrowth is also associated with parenteral nutrition-associated liver disease, and it's not exactly sure the exact mechanism. They've just noticed a correlation in the studies. The same thing with catheter-related sepsis. For some reason, the more incidence of sepsis, the more progressive your liver disease. And then the last bullet, the high parenteral protein, fat, and/or energy intake, is one of the only bullets on this slide that we can actually control. If we overfeed the patient through parenteral nutrition, then we are more likely to give them a more severe and progressive liver disease. So we want to make sure that we're not giving them too much nutrients or too much for what they need. The diagnosis of parenteral nutrition-associated liver disease is really made by taking a liver biopsy and actually visualizing the liver histopathology to see if there are changes. However, we implement preventative measures as soon as we can in the patients that we know are dependent on parenteral nutrition. As soon as we see any type of liver damage, we're going to start therapies to prevent the development of progressive liver disease. So the first little bump in liver transaminases and conjugated bilirubin, we're already thinking about trying to make sure that liver disease does not, that we're not getting permanent histopathological changes in the liver for as long as possible. We're not really sure exactly how parenteral nutrition causes liver disease. We don't know the exact mechanism, but we have correlated it with intravenous lipid emulsion use. One of the things that we think causes liver disease in American formulations is the fact that it is omega-6 based. And if you remember, the omega-6 fatty acid is the one that's the pro-inflammatory fatty acid. In Europe, they use a fish oil-based lipid that's omega-3 heavy. This lipid has been shown to prevent and even reverse parenteral nutrition-associated liver disease in adult patients. It's weak studies, and unfortunately, we do not have access to the fish oil-based lipid product, which is called Omegavin. You can get it through the FDA, but it takes months and lots of paperwork, and it's extremely expensive. So we most commonly, and almost every patient will use the soybean oil phospholipid from the egg yolk and glycerin formulation that we have here in America. So it is quite upsetting that we know that our product is inferior just based on the fact that we've seen so many cases of liver disease from parenteral nutrition from the lipids, whereas Europe has already seen better results and we can't get it here. However, we can still do things with our current lipid formulation that we'll talk about on the next slide. One thing that is important to know about parenteral nutrition-associated liver disease is that it will progress to end-stage liver disease. We can't remove the causative factor because of the fact that these patients are dependent on the nutrition to survive. So we really want to prevent it as much as possible. One of the ways that we do that is really enteral feeding. So the less time they're on parenteral nutrition and the less amount of calories that they rely on through parenteral nutrition, the better. We can reduce the amount of trace element supplementation. So that's another thing that's been correlated with progression of parenteral nutrition-associated liver disease is giving them too many trace elements. So we've found that if we give them multivitamin and their TPN only every other day, or maybe only 3 times a week, that the patient is still getting enough trace elements that they're not going to be deficient, and they're not getting too much to where it's going to contribute to their liver disease. Another method that we do to try to prevent the progression of parenteral nutrition-associated liver disease is space the lipid emulsion. So we'll either do 2 times a week or every other day or Monday, Wednesday, Friday. We just want to give them enough to prevent essential fatty acid deficiency and to give them enough to where they have fats to survive, but not too much to where it's contributing to the liver disease. There are 2 medications we'll talk about on the next slide that can be used to help prevent the progression. And then a patient may be able to get a liver and intestinal transplant. They won't be able to get just a liver on its own because unfortunately we know that even with a brand new liver, they're going to develop liver disease again because they're dependent on parenteral nutrition because their intestines have failed. So they may be able to get the combination if they're otherwise healthy. The 2 medications that we have are ursodiol or Actigol and phenobarbital. They work in completely different ways. The Actigol improves bile flow and reduces gallbladder stasis. It does this by actually decreasing the cholesterol content of bile and bile stones by reducing secretions of cholesterol from the liver. So this basically decreases the biliary sludge and it helps things flow out of the liver to prevent any type of backup. There's 2 different dosing regimens. One's for treatment, one's for prevention. However, if we have a patient with short bowel syndrome that's completely dependent on parenteral nutrition, we pretty much will start the treatment dosing right away before we've ever done a liver biopsy to confirm histopathological changes. Just because we want to maximize everything we can to do to prevent the liver disease. And I know I rarely actually ever see the prevention dosing used, but you can start that dosing as early as day of life 3. And that might be good for patients who are not necessarily going to be lifelong dependent on TPN, who might have a chance of getting off TPN. It is available in an oral solution, so that's a pediatric dosing friendly dosage form that we have. Phenobarbital, as you know, is a CYP enzyme inducer. It induces a lot of enzymes within our body, so that is actually what we're using it for. It induces hepatic enzymes to promote bilirubin conjugation. So again, it helps the bilirubin get out of the gallbladder to be conjugated and excreted, so it's not building up inside the liver to promote histopathological changes. However, since we are using it for its enzyme induction effects, it does have a lot of drug interactions, so definitely keep that in mind before recommending this agent. It does also have a lot of fairly serious side effects. I know parents really don't like the CNS depressant. They don't like how drowsy this medication can make their child. You'll notice that the dose is much smaller than any type of anti-epileptic dose that we would use for this medication. And it does have an oral solution as well, so that's definitely helpful when trying to give medications to our pediatric population. That sums up our parenteral nutrition-associated liver disease, which is one of the most severe and complex conditions that you'll see in these patients. Another one that we see that affects pretty much their quality of life is short bowel syndrome associated diarrhea. It's most severe in the immediate postoperative period because the whole system of the intestinal tract has just been disrupted. You have a lot of malabsorption because the intestines haven't had time to do any of that adaptation yet. It will improve in time in most cases, but some patients will continue to have chronic diarrhea, especially if they lost a portion of their colon in the surgery. We also have changes in gastric motility immediately postoperatively. It's actually a hyperactive motility system, so not only did we lose surface area of the bowel from the surgery for absorption, but we have this kind of panic mode gastric motility going on that's going to further inhibit the absorption. So if the patient did have resection of the colon, then they're very likely going to have electrolyte imbalances and dehydration because of all the water loss. If they lost a portion of their ileum or all of their ileum, then you're going to be more worried about fats. They might develop a fatty acid deficiency, fat-soluble vitamin deficiency, and they're not going to reabsorb their bile salts, so they're going to be even less likely to break down the fats, let alone absorb them. The goal of management of this short bowel syndrome associated diarrhea is to really just get them to a number of bowel movements that is not going to affect their quality of life and will also help enhance the absorptive properties of whatever intestines they have left. So usually that's around 1 to 3 bowel movements per day, roughly. Basically whatever is acceptable to the patient can be acceptable for us, as long as everything is in check, like the hydration and the electrolytes. So those are going to be our first and foremost concerns, are keeping the patient hydrated and keeping their electrolytes in check. It's hard to say exactly which electrolytes the patient will need replaced based on which section of their bowels removed, because there is a lot of overlap with electrolyte absorption, and that is one of the things that does adapt very well. However, potassium and magnesium are the two that we lose the most in diarrhea, so these are very commonly going to be the ones that we're going to have to replace, and we might have to put a lot of this in the patient's TPN. If you remember from the GERD lecture, we talked a little bit about magnesium as an antacid, but one of the side effects of magnesium supplements enterally is diarrhea. So here we are trying to use magnesium to replace electrolytes because the patient's having diarrhea, but we're going to give them more diarrhea if we supplement this enterally. So the best way to give them back their magnesium is to put it in their TPN. But if you can't do that, or if the patient is completely dependent on enteral feeds, then they might have to go in and get periodic IV doses, just mag supplements to keep their mag levels up. there are also a few medications that we can use to help manage the diarrhea. One of them is loperamide, and I actually see this fairly commonly in our patients with short bowel syndrome that we see in the hospital. It does act directly on the intestinal muscles to slow down the peristalsis. So this allows the intestinal contents to remain in the intestines longer to allow for further absorption. So not only is it getting rid of our diarrhea that's affecting the patient's quality of life, but it's actually helping to improve our absorption. If you look this medication up in Lexicomp, you might see that it is contraindicated in patients less than 2 years of age, but here on this slide I have dosing for infants 2 months and older. So that contraindication, take it with a grain of salt. That's really based on your average otherwise healthy child that's 2 years old with one single episode of diarrhea because he ate too much applesauce. This is a very different patient population. They have an underlying reason to have diarrhea. They don't absorb things like your average child. So there are pediatric studies that show that using loperamide in patients as young as 2 months is safe. I've actually seen it used even younger than that in one of our short bowel syndrome patients. But it is pretty well tolerated, and it is used very frequently. You'll also notice that the dosing is different in patients with short bowel syndrome versus the average dosing for diarrhea. One of the most important clinical pearls about this medication is that although it is available in an oral solution, most patients can't tolerate the oral solution because it contains sorbitol. As you know, sorbitol has a very high osmolarity, and that pulls water into the intestines, and it can further exacerbate diarrhea. So most of these patients, you will have to crush up a tablet if they're unable to swallow a tablet themselves. The next medication that we use to manage diarrhea in patients with short bowel syndrome is Lamodal or diphenoxylate atropine. And Lamodal is the active agent here that actually inhibits the GI motility, and as you know, the atropine is just there to discourage abuse. So the atropine is really what we get our side effects of this medication from. If you remember the little rhyming acronym for, well, it's not an acronym, but mnemonic for remembering the anticholinergic side effects, you can't see, can't spit, can't pee, can't poop, so you get blurry vision, dry mouth, urinary retention, constipation. You can get the euphoria from the diphenoxylate portion since it does work on the mu receptors, which is also what our opioids work on, and you can get some numbness. So the dosing there is listed on the slide with a max of 10 milligrams per day. If the patient has had their ileum removed, so they have steatorrhea, which is fatty diarrhea, obviously the first thing we would want to do is recommend a low-fat diet if they do receive any enteral feeds or any substantial enteral feeds that are more than just trophic feeds. And we can recommend cholestyramine or Questran. However, this medication is not used very often, mainly because it just contributes more to malabsorption. This medication works by binding, it's a bile salt binding resin, so it's going to keep our fats from getting absorbed. Really, we want this medication to bind the fats that aren't getting absorbed, but it's going to compete with our intestines, and it's going to bind some of our medications or some of our fats before the intestines have even had a chance. So for that reason, it's used with caution. We don't want to contribute to a patient's fatty acid deficiency who's already at risk because they've had their ileum removed. So they're also going to be at further risk for fat-soluble vitamin deficiency. So really think about the risk versus benefits before starting a medication like this. The next complication that can be chronically managed in patients is gastric acid hypersecretion. Gastric hypersecretion is usually a transient effect in patients postoperatively just because you have that initial stress reaction. However, it can be a chronic issue because depending on which portion of the bowel is removed, you can lose the hormone feedback regulation. So like most systems in our body, the gastrointestinal tract works on feedback. As contents move throughout the intestines, there are hormones released that tell the upper portions of the gastrointestinal system that they don't need to work anymore. So usually once our food gets down to the lower portion of the intestines, our stomach will stop secreting acid, but if we lose this feedback mechanism, then our stomach's just going to continue to secrete acid. This can actually worsen diarrhea. It can worsen the malabsorption of fats because you're going to be substantially lowering the pH even in the intestines, and it can lead to peptic ulceration, so it's definitely something that we need to consider and take control of. The medications that are the mainstay of therapy, the number one recommended, are the proton pump inhibitors. You can actually see your GERD lecture for the various agents and side effects and everything. The only difference that you will notice is that we do use higher doses for gastric hypersecretion in patients with short bowel syndrome. If you remember, the PPIs all generally have a dose of 1 milligram per kilogram per day, but in gastric hypersecretion and short bowel syndrome, we'll give 1 milligram per kilogram twice a day. So they definitely need a complete acid block. H2RAs are not favorable in short bowel syndrome. Octreotide is one medication that we can use immediately post-operative. The gastric hypersecretion can lead to diarrhea. Like I said, it can also put the patient at extreme risk for ulceration. Patients are already at risk for stress ulcers post-operatively. And then if you add on gastric acid hypersecretion, diarrhea, patients not being able to take anything by mouth, they're even at a higher risk. So we can give them octreotide, which is a synthetic molecule that mimics natural somatostatin. Somatostatin is one of the hormones that's released by our duodenum that is part of that feedback regulation that tells the stomach to stop producing acid. However, you can see that this hormone also has lots of other effects within the body, so we're going to get a lot of side effects associated with this use. It's only available intravenously, so it's only used immediately post-operatively for patients that we just really can't control their diarrhea and the gastric acid is contributing to their diarrhea, or if they already have an ulcer that's developed and we need to promote its healing. We don't use this in patients less than 2 years of age because of the risk of cholelithiasis, and we especially don't use it in our neonates because of the risk of necrotizing enterocolitis. So don't see this very often, but I wanted to throw it in there just to point out how big of an issue the gastric acid hypersecretion can be. There are some studies in adults that have shown that omeprazole is just as effective for controlling gastric acid-induced diarrhea as octreotide is. So we really reserve it for patients that have already failed PPI use. One of the last complications that we'll talk about for patients with short bowel syndrome is small intestinal bacterial overgrowth. The way that small intestinal bacterial overgrowth occurs is because the whole systematic regulation of the intestines has been disrupted. So our entire intestinal tract is lined with bacteria. However, the bacteria in the colon are supposed to stay in the colon, and the bacteria in the small intestines are supposed to stay in the small intestines. Or they can be periodically flushed down to the colon, but the colon can handle it. The bacteria is most concentrated in the colon because we're not worried about nutrient absorption in the colon. In the small intestines, we need the surface area, we need our intestines to be exposed to the contents to be able to absorb them, so we don't want a high concentration of bacteria. Normal peristalsis will keep this all in check as it moves contents down throughout the gastrointestinal system. However, after surgery, the rhythmic peristalsis is interrupted. Sometimes it's never fully recovered. So instead of having a slinky-like movement throughout your intestines, you just get more of like a bouncy house movement where things are randomly contracting and going back and forth, and it allows the colonic bacteria to over-multiply and to climb retrograde up the gastrointestinal system. The signs and symptoms of small intestinal bacterial overgrowth can sometimes just mimic normal short bowel syndrome, like malabsorption type symptoms, so it can be hard to diagnose. Abdominal bloating and abdominal distension and excessive gas occur because the bacteria are starting to take the nutrients that we thought that we had for our intestines. So when the bacteria digest, gas is the byproduct, so we get a lot of gas. We also can get a lot of weakness, weight loss, and muscle cramping because of the electrolyte disturbances. There are some official ways to diagnose it, but most commonly we see prescribers just take a thorough past medical history, um, evaluate the patient and their short bowel syndrome, and can do just a trial of antibiotics. However, you can culture the direct aspirates of the small intestinal contents to see if there are any colonic bacteria in there. You can also do the hydrogen breath test, but this is more just for adults. Hydrogen is actually a byproduct of bacterial digestion of carbohydrates, so that our bacteria should not be digesting carbohydrates. Our intestines should be absorbing them, so if we have colonic bacterial breaking down our carbs, then we get hydrogen and we will breathe out the hydrogen. However, this is not reliable in pediatrics because of the smaller lung volume and the inadequate breath collection. A lot of times you can't get enough breath to accurately measure how much hydrogen is there. So more often, you'll see prescribers diagnose based on a thorough history and physical. The complications of small intestinal bacterial overgrowth are malabsorption, as we've talked about throughout the past few slides, which can lead to further deficiencies in weight loss. We lose production of vitamin K because that is a bacteria producing vitamin, and the colonic bacteria will overgrow and invade the bacteria that make our vitamin K. We can also get intestinal scarring from the colonic bacteria being in the small intestines. And we can also get gram-negative sepsis because the colonic bacteria will actually break through the tight junctions in the small intestines, which allows the gram-negative bacteria to seep into the bloodstream. So if you see a patient with gram-negative bacteria, that is from small intestinal bacterial overgrowth more than likely. And if you see a patient with gram-positive sepsis, it's more likely from their central line because it's more likely a skin bug like a staph or strep that got into the bloodstream through the central line. Just a side note. It's also important to note that even after a course of antibiotic therapy, which is a usual course of antibiotic therapy is 7 to 10 days, the condition usually recurs. Most of the time this is because of the dysregulated peristalsis that occurs in the gastrointestinal system postoperatively, and that usually, if it hasn't recovered within the first couple of years, it usually won't recover. So this condition is unfortunately just going to keep returning for these patients. We can also worsen the condition by increasing the pH of the intestinal contents with H2RAs and PPIs. Antidiarrheals can make it worse and can lead to toxic megacolons, so we definitely don't want to use those in patients with small intestinal bacterial overgrowth. So the way that we manage it is through antibacterial agents. We want to suppress the gram-negative agents that are not supposed to be in the small intestine. So we want to kill them to get them back to a normal amount to where they're not overgrowing the small intestines, and then hopefully the normal flora will return after we suppress them for 7 to 10 days. The first agent that we use is neomycin, which is an aminoglycoside. And as you know, aminoglycosides have really no gram-positive coverage. They cover a lot of gram-negatives, so they're appropriate to use. We give it orally, and it's actually not absorbed systemically. However, it's not recommended to exceed 3 weeks of therapy, which usually we don't. But because of the colonic bacteria getting through the tight junctions, we have kind of leaky intestines, and the medication can actually become absorbed if we use it for a prolonged period of time. And as you know, since it's aminoglycoside, it can lead to nephrotoxicity and or neurotoxicity. Rifaximin is another agent that we will use. It doesn't have as much data in the pediatric population, so I don't see it as our first go-to. And the dosing is a little bit more rigid. There is a compounded oral solution available, but it's not always readily available, and it's kind of difficult to make, so we typically see tablets. The side effects, such as increased ALT, are also not favorable if this patient also has parenteral nutrition-associated liver disease. Metronidazole is an agent that I will see commonly used because it does have good anaerobic coverage as well as gram negatives. It is available in oral solution, and we do want to give it orally because we want the local effect. So you can give it IV for patients that don't tolerate it, but orally works just as well, if not better. Ciprofloxacin is another. Oh, back to metronidazole. The dosing is a little bit lower than dosing that we would use for a systemic infection. So we would do at least 3 times a day for a systemic infection, so this dosing is a little bit lower. And you can probably find more dosing out there in the literature, and you could probably support other doses as well. Ciprofloxacin is another agent that is not very favorable in the pediatric population. And does anybody know the exact age cutoff that we would not give ciprofloxacin? Well, the answer is there is not an exact age cutoff. Ciprofloxacin is just always reserved as a last line agent. We know that there is an increased risk for tendon rupture, and that risk can decrease as our patients get older. So our teenagers might not be at as much of a risk as our toddlers would be, but we still wouldn't use it first line in our teenagers when we could use something like metronidazole or neomycin. It does come in an oral suspension. However, the oral suspension will clog a feeding tube. So if the patient does need to get the medication through a feeding tube, we would have to crush a tablet. Another medication that we use is Augmentin, and you'll notice that all of these antibiotics are all from different classes. They all have different coverage, and it's because we don't really know exactly what bacteria specifically we're trying to target. We just know that there's been an overgrowth of colonic bacteria, which is more than likely anaerobic and gram negatives. So Augmentin, or amoxicillin clavulanic acid, does have anaerobic coverage as well as some gram negatives, so it is appropriate to use. Again, this is lower dosing than what we would see for a systemic infection or something like a pneumonia. We do have oral suspension, which is favorable for pediatrics. This is not one of our first line agents because of the side effects. Clavulanic acid is notorious for causing gastrointestinal cramping, which is probably one of the symptoms that they're having for this small intestinal bacterial overgrowth. So it's not favorable for that reason. Another mechanism of using these antibiotics is a process called antibiotic cycling. There's very limited data available to support this. However, for patients who really have recurrent episodes of gram-negative sepsis, or for patients that just have recurrent episodes of small intestinal bacterial overgrowth that's really affecting their quality of life, it can be something that you can consider for a patient. It's where you use one antibiotic for 7 days, and then for the next 7 days you use a different antibiotic, and then you repeat the cycle. So you're basically just always suppressing a different group of gram-negative enteric organisms. If you read about small intestinal bacterial overgrowth in literature, you will find stuff about probiotics. There are people that think probiotics are a big answer to this problem, but there are people that do not believe so, and we really don't have the data to support the regular use of probiotics. The idea is that it promotes maintenance of normal flora by directly exposing our gut to good bacteria. There's 2 agents that we would see most commonly reported in the literature, but the studies are not well designed. There's only one case control study. There's mostly case reports and no randomized controlled trials. There's no consistent dosing. I wouldn't even know how often to recommend administering these agents or what type of doses to use. So there's not enough data to really implement this into clinical practice or for me to go out of my way and recommend starting probiotics in a patient. But hopefully they will be continued to be studied so we can find out if they are safe and how to use them safely. Right now, we've seen reports of lactobacillus sepsis and D-lactic acidosis, which are pretty severe side effects. So they're more than likely out of favor than in favor. And finally, we'll talk about surgical procedures and then investigational medications. But there are some surgeries that we can do, and I know you're thinking surgery is what caused this problem to begin with, because we had to remove the patient's bowel. But we can put in various feeding tubes to help the patient get enteral nutrition if the patient needs it. We can also, more than likely, a lot of patients will have some type of ostomy bags for collecting the waste. And then we can have, the patient can have a serial transverse enteroplasty procedure or a step procedure done, which I'll talk about more on the next slide, or they can have an intestinal transplant. However, more than likely, they're going to need more than just a new intestine, since their failing intestine has already put a lot of stress on all of the other organs. We actually have a patient in the Florida area that is the first patient to receive a 5-organ transplant. He's just a little toddler, and he's already had a new stomach, new pancreas, new small intestine, large intestine, and liver. So he was born with omphalocele, and he had a 5-organ transplant at the same time. So more than likely, they don't just get an intestine, but more than likely, they also don't get 5 organs at once. The step procedure is something that we're seeing more commonly. So it's a way to actually lengthen the intestines to try to increase the absorptive surface area. So this top picture is the intestine beforehand, and the bottom picture is post-step procedure. The acronym is fitting because the intestine does kind of look like a step afterwards. You can see that they left the nerves intact to keep innervating the peristalsis, but they made incisions in the sides of the intestines and then stitched it up. And around the stitching will actually heal. You'll get villi to grow, and you will increase the absorptive surface area. And this is in hopes of improving the amount of enteral nutrition that the patient is able to receive. Potential new therapies that we are seeing in the literature are really focused on giving a patient a functioning gut. So we've removed the portion of the gut that was life-threatening to the patient, that was necrotic and needed to be removed before it caused further complications. And now they're left with a intestinal tract that's too small to meet their nutritional needs. So how can we make their intestine grow to where it's long enough to give them, to meet their nutritional needs? The one on this slide that has gotten the farthest in the literature is the GLP-2, or the glucagon-like peptide 2. It has already gotten to phase 3 trials, but we still do not have near enough data to be able to recommend this to patients, especially in the pediatric population, because we don't have any data in the pediatric patients. GLP-2 is created by the distal ileum and proximal colon. And the reason that this hormone was studied is because they found that patients who had GLP-2 producing tumors actually have small bowel hyperplasia. So we have a case study of 8 patients that found improved absorption of nutrients and increased body weight, but there is definitely more to come before this becomes a mainstay of therapy. So it's just interesting to think that maybe we might be able to help these patients regain their absorptive capacity in what other intestines they have left. That concludes our short bowel syndrome lecture. So like I said, please feel free to email me or contact me should you have any questions. Thank you.